afternoon and welcome to this webinar from MS Focus, the Multiple Sclerosis Foundation. I'm Cherie Binns, the Patient Healthcare Liaison for the Foundation, and today we're going to share with you some information that came out of the Consortium of Multiple Sclerosis Centers annual meeting in Nashville, Tennessee, 3 weeks ago. I have with me behind the scenes Bhavya Suri, who is um, our tech person for this, but she was also one of the attendees at this conference. I would ask you to hold your questions. I'll tell you how you can ask them until we've presented the information. There is a fair amount to cover today, so if you could just hold those questions for a bit. Bhavya, could you start the slides, please?
Sure, give me 1 second. Okay.
Okay, so we're going to talk to you a little bit about what's new in MS treatment and research. We're going to be covering um, new techniques for MRIs that give us a better look at what's really going on, some symptom management tips, an update on what we call phase 4 research, which is real life use of a product that has been approved after phase 3 of a study. We're going to talk about a little bit about pregnancy with MS, aging with MS, and um, let's see. I think that pretty much covers it. So, Bhavya, next slide, please. This is the crew of 6 of us that went from the MS Foundation staff. So from left to right, you see Bhavya Suri, who is also on this call, myself, Natalie Blake, and Casey Minnis, who are our 2 co-executive directors. Monique Frazier, who is in charge of our home care program, and Marcia Harris, who does all things related to support groups. So what you're going to be hearing today is a compilation of their experiences with the foundations. We kind of sort of split up in order to get as much ground covered as possible. Not pictured here, but also affiliated with the foundation are Sean Feliciano, who is one of our lived experience advisory panel members. This was her first conference. Excuse me. Um, Sean is one of our bilingual Spanish speaking members of the advisory panel, and also Dr. Ben Thrower, who is the senior medical advisor for the foundation. We started out the conference with Dr. Darren Okuda giving an absolutely engaging talk about MRIs and how we have begun to use them in a way that shows us even more of what we hoped to see. He talked a little bit about using artificial intelligence to read MRIs and how that has refined the diagnosis with neuromyelitis optica spectrum disorder, with migraines, with vasculitis, and also with something called MOGAD. And in a minute, Bhavya is going to share some of that information with you. Bobby, if you could go back to the previous slide for just a second. One of the things that Dr. Okuda said was that they had a radiologist will read your films and they'll generate the report that you get on your MRIs. And even with the most skilled radiologists, they're only picking up details that might lead to a diagnosis 72 to 80 or so percent of the time. But you add an artificial intelligence model to that, and it increases to 98+% accuracy. So I know you may have been getting no changes on your MRIs over time, and all of a sudden you get this very detailed report that is showing something, and that the reason that is because they're starting to use some artificial intelligence. Dr. Akuda also showed us how certain color enhancements, particularly in 3D MRIs, really show up how a lesion may be getting smaller or even growing when without that 3D on a 2D MRI, it may look exactly the same and unchanged. But by color enhancement and that three-dimensional MRI, we're beginning to see those changes more clearly. I know that this presentation really excited Dr. Thrower. He really thought it was very, very well done. I'm going to let Bhavya take over for a bit and on the next slides, and go take it away, Bhavya.
Thank you, Cherie. And thank you for the introduction. Hi, everybody. My name is Bhavya. I am the co-editor and health educator for the Multiple Sclerosis Foundation. I'm usually in the background, but I just wanted to share my experience for the CMSC that we all attended and were fortunate enough to go to this year. So one of the courses that I attended actually talked about the differential diagnosis between MOGAD, NMOSD, and then MS. I'm sure that in the recent studies, if anybody has read any of them, there has been some clinical features that can help now to diagnose the differences between the three, because previously one of the two, NMOSD or MOGAD, might have been confused with MS, and therefore treatment may have been delayed or the wrong treatment may have been given. So one of the first things that was discussed was the diagnosis of MOGAD. And this comes from a study that was actually just published in a journal called the Lancet Neurology last year. And it discusses what clinicians are looking at when they're diagnosing specifically for MOGAD. So one of the main things is problems with the eyesight with optic neuritis. So that can cause either eyesight issues. You can have it unilateral, meaning only on one side, or bilateral on both sides. But this chart and these slides will be available for anybody who wants them after the presentation. This is how they will differentiate. The next slide is the more important one that I captured when we were at the webinar or the session itself. So this talks about the three differences that you can see. So as far as the phenotype, and that is just showing exactly where it is in terms of MOGAD versus the NMOSD and the MS. So you can see in your MS, there's an area called the cerebellum in your brain, and that's where you're seeing the issues. As far as MRIs at the attack of these three different diagnoses, you see that in MS, it's well-defined regions and they are more prominent and larger, whereas in MOGAD and NMOSD, they're not as well-defined, so you might see them smaller. And there were MRI images, so if anybody's interested, I'm happy to send the links to the studies that were shared. The one thing I did want to point out is the progressive phase, which is the last row of this table. With MOGAD and NMOSD, there is no progressive phase. And with MS, you do see the progression. So going into that, I just wanted to talk about the severity, and this was the other table to help distinguish the three different diseases that all are due to demyelination. So you see that the last row, it talks about recovery and severity, and you see a poor recovery with NMOSD, a good recovery with MOGAD, and then you see just a lower or slower progression of MS. But as we all know, there is no full recovery as of yet. And all of these different ways that physicians are now able to differentiate in the diagnosis can actually help when it comes to being able to diagnose a patient coming in with issues that might, or symptoms that might present like MS, but maybe something entirely different. And I will hand it back to you now, Cherie. Thank you.
And you can stop sharing your screen when you're able to do that. Perfect. Um, Another thing that Dr. Thrower asked us to mention, they did some talk in one of the AI episodes or sessions that he went to on MRI technology, is something called synthetic MRIs. And these are designed, hopefully in the future, to make the process of having an MRI much shorter, much less difficult for people who might have discomfort that keeps them from laying as perfectly still as they should in the tube. In many cases, the synthetic MRIs are allowing people to be in the MRI machine for 10 or 15 minutes instead of 45 minutes to an hour. And so the way that that works is that they'll do a sequence like a flare or an axial or whatever sequence they're doing. And the AI generation asks it then to predict based upon what this particular imaging is showing, what the next sequence of imaging is going to show. And for the most part, as long as it's being done on the same MRI machine, it tends to be pretty good in predicting what's going on. So that's something that's still being developed. It's not being used in the real world setting yet, but it does have to be used on the same exact MRI machine. And as we all know, that is not always feasible. So, but he did want me to let you know about that. Um, there's a difference, a huge difference in the MRIs of somebody who has been on a disease modifying therapy over years of having an MS diagnosis and those who have opted to go medication free. Huge difference. There is so much more damage in the central nervous system on those who are treating their MS naturally with things like lifestyle changes, diet, supplements, that sort of thing, than there is with individuals who are treating it with a disease modifying therapy, particularly one of the more moderate or high efficacy therapies like the oral medications or the infused medications, not the injectable medications, with the exception of Kesimpta, which is the newest injectable medication. Kesimpta and in the B cell infusions, such as Ocrevus, Briumvi, Rituxan, Truxima, um, are all considered now to be the highest, the most effective of all of the MR or the MS medications. In a minute, when I get into the phase 4 or real world studies, I'll give you some more information on the statistics that they shared with that. Um, Next, we moved into some symptom management. Several of our staff went to various symptom management sessions, fatigue being a big one. Now, the gold standard of fatigue is subjective. In other words, what you tell the doctor, this is crippling to me. I just feel like I can't function, I can't move. MS fatigue is not a sleepy fatigue. MS fatigue often will keep an individual from sleeping because the fatigue is so profound. Um, and there's a primary and a secondary fatigue. So the primary fatigue could be caused by the placement of your MS lesions and by the actual disease course itself. It also could be made worse by the fact that an individual is not yet on a disease modifying therapy or has chosen to be off of one. That really does make a difference in the fatigue levels. Those that are on MS um, disease modifying therapies often report lower levels of fatigue. The secondary fatigue could be caused by something such as sleep interruptions. your bladder's overactive, and so you're waking up several times at night to empty it. Or maybe you have obstructive sleep apnea. About 50% of those of us with MS have some sort of a secondary fatigue cause, such as obstructive sleep apnea. Um, and so, if you are excessively fatigued, particularly if you don't feel rested when you wake up in the morning and you have daytime sleepiness, you really need to have a sleep study done, because that secondary fatigue is often very treatable, which can lift the primary fatigue and make it seem less dangerous. One of the things that was brought up with the fatigue medicine is that no one should be on the anti-fatigue medicines every single day. Most of the fatigue medicines are prescribed so that you have enough to take daily if you need to. They lose effectiveness over time, and not one of the anti-fatigue medications that's on the market that has had placebo-controlled trials, meaning they give you a pill that looks like the real medication used to treat fatigue, that has no active ingredient in it, and then they have a group of people taking this placebo, and then they have a group of people taking the actual medication. Not one of the medications, including Provigil or amantadine, was any more effective than what the placebo was. They also have a tendency in the real medications to do things like raise your blood pressure or raise your heart rate, which can cause further problems and can actually add to fatigue. So, if you're taking one of these medications, you should only be taking them on days or at times when you really need that extra boost of energy. For example, maybe it's the day of your clinic visit, and you've got a drive each way, and you got maybe an hour or more to be at the facility. And so you've got a good 4 or 5 hour chunk of time that you need to have as much energy as possible. Those are the absolute only times you should be taking these medications. Um, when I was working full time in the clinical arena, I would only take the medication for the days that I was having to see more patients in a given day. I was a visiting nurse and a case manager with our local visiting nurse services. And I would often have to see 7 or 8 patients a day, driving a total of 90 to 100 miles to see them all during the day. And that was often a 9 or 10 hour day. So I would take them on those days, and on days when I had a lighter caseload or could be in the office for part of the day, I didn't take it at all. I found personally that taking a medicine for fatigue longer than 3 days in a row, um, I had trouble sleeping at night, which added to my own fatigue. My blood pressure did go up, my heart rate did go up. I tended to be more irritable and more moody. And I've heard that from a lot of other people too. So if you're having some mood problems, anxiety, irritability, all of those things could partially be attributable to an anti-fatigue medication. So be careful of that. Bowel, bladder, and sexual dysfunction were also discussed at other webinars. And one of the things that they pointed to at these webinars was the necessity, particularly if there's a bowel or bladder incontinence. Bowel, bladder, and sexual all come out of the same nerve root, which is right around T11, T12. So it's right at the bottom of your T-spine films. Persons with a lesion in that area will often experience all three: bowel, bladder, and sexual dysfunction. If you're having trouble with incontinence of either urine or stool, um, a a pelvic floor therapist should be a member of your healthcare team. Pelvic floor therapists are now pretty pretty numerous around the country, particularly in urban areas, not so much in rural areas. They started out really gaining ground in that discipline in the spinal cord injury arena, and that's extended into the MS arena. So a pelvic floor therapist is somebody that should be part of your team. Sexual dysfunction, again, can have a number of different causes that are both physical and psychological. And that's something that we just tend not to talk to our healthcare team about, but we were encouraged to do so. Cognitive decline. We've heard for years that it helps if you've got memory problems to stimulate your brain by doing puzzles, by doing brain games. And the research with MS, particularly, that may be true if you've got an early Alzheimer's or you've got a mild cognitive impairment that may be related to age. Those sorts of things keep your mind sharp. But with MS, what's really rising to the surface right now is the fact that those people who are more active, who get in their 150 minutes of activity at least every single week, and that includes like doing the laundry and carrying your laundry basket upstairs and going up or downstairs to put away clothes or walking the dog or things like that, gardening, they're all considered part of that 150 or minutes of activity that we should get in during a given week. Those persons who do that, as well as having a regular exercise routine, stretching, strengthening routine, treadmill, whatever, those individuals maintain cognitive function at a far greater rate than those who are more sedentary. Um, and also, exercise seems to slow brain atrophy or shrinking, which can often be associated with cognitive decline. Art therapy, particularly music and dance therapy, has been shown to improve mood and also improve the quality of life for those who regularly participate in them. And we at the MS Foundation have regular art therapy and dance therapy classes that are online for people that don't have access to them in their community. So go to msfocus.org and click on to our events, and you'll see when things are happening for each of the various offerings that we have online. Shared decision making was brought up by a couple of the presenters in sessions that the 8 of us went to, and talked about how it really improved the doctor-patient relationships. And over the last 20 years or so, we're seeing fewer and fewer providers, fewer and fewer doctors who are treating people with MS who tell people what to do. They have a conversation about why they're suggesting something and ask the individual if they think they might be able to try this for a while. And they listen to your reasons why you think maybe it wouldn't work for you, and then you work together to find a way to do what's best or a compromise in that. So shared decision making is an important function of that. Next, we went into real world studies, or what we term phase 4. Um, Research is done in 3 phases. So, phase 1 tests a concept with a small group of individuals. It's something that might have worked in the lab, and we want to see if it bears out in human beings as well as perhaps lab animals. And that's usually not much more than maybe 100 individuals in 1 or 2 sites to test that concept. Depending upon whether it's a drug treatment trial or whether it's something like an exercise trial or a trial for a device, that phase one could last as short as maybe 6 months, but generally about a year. Phase two, if the phase one has been effective, it goes on to phase two. And phase two talks about it's a larger group of people. It might be 500, it might even be 1,000 individuals in phase two at different sites around the country or even around the world. And the two trials will have what we call arms of a trial. So there'll be at least two, possibly even three or four arms of a trial. So if it's a drug trial, it might be two arms with different doses of drugs, and it might have a third arm that's a placebo. With MS drug trials now, we are no longer doing placebo because we have so many effective drugs that treat MS. So it might be an effective drug to treat MS, such as teriflunomide or Aubagio, which is a pill form of a drug, if it's a pill that's being tested. And they will put that drug, the active drug that's currently used to treat MS and approved to treat MS, in the same uh, in a dispensary in a pill form or a capsule form that looks exactly like it's marketed in its brand name form. So you don't know whether you're getting the brand name drug or whether you're getting one of the clinical trial drugs. And and so they usually do that for at least a year, mostly 2 years with drugs like that, before they unblind those arms. Um, and then if that's effective, they'll go into a phase three trial, which could last 3 years, sometimes even a little bit longer. And what they might do is have 2/3 of the individuals in the trial on the the drug, the active drug that they're testing, and a third on the already approved drug to look at that before it goes to the FDA for approval. After approval, the drug is then used in the general population. We call that phase four. We've got enough information in phase four of several of our medications now that we know really a lot more about them. We've got the population that's been in the clinical trials. So we've got basically 5 or 6 years of people that have been in clinical trials before the drug has been approved. And now with Ocrevus, for example, that was approved in 2017, we have another 7 years of information on that. So what that's telling us, the data that we've collected from the beginning of the clinical trials till now, is showing us that 8 out of every 10 individuals that are on Ocrevus are showing absolutely no disease progression after 10 years. 1 out of every 3 individuals with with primary progressive MS are showing no disease progression, no change in their EDSS or abilities to function after 10 years on Ocrevus. One of the things that brought up is that a new clinical trial is beginning for individuals with primary progressive with a different dose of that drug, so that we may need to give you a slightly higher dose or maybe even a greater frequency in order to slow that progression in that other 2 out of 3. So there is more work on primary progressive with that drug. There are new trials about to begin with a different dosing with primary progressive. Patients on higher efficacy therapies, such as the B cell therapies that I mentioned earlier, are actually starting to naturally repair their own myelin. We have the ability to repair our myelin, but what happens is people on that category of drugs is knocking down the inflammation in their central nervous system so that natural myelin repair can happen. Um, it's happening more in the younger individuals, in those in their 20s and 30s, than it is in those over 40, merely because we've only got so much actual myelin repairability built into our systems. There are some biomarkers that you've heard about over the last few years, such as neurofilament light chain. And during this past year, there has been a manual that's been available now to all prescribing physicians just for requesting it. You write to mscare.org, which is the consortium of MS centers, and they now have a booklet available for all of our doctors upon request that tells them how and when to use neurofilament light chains and what the readings on that indicate. Now, this is a biomarker that tends to be elevated in a number of different diseases, not just multiple sclerosis. And so you'll find it elevated in Alzheimer's disease. You'll find it elevated in lupus and rheumatoid arthritis. And it may be elevated in Lyme disease. So it really is a marker of inflammation in the system. So it can tell us if your neurofilament light chain is elevated and you're trying to decrease the number of times. For example, if you have an annual MRI and you've been stable for 4 or 5 years, your doctor may indicate to you that it's okay to have an MRI done every 2 years. Neurofilament light chain may be done a couple of times a year, may be a good way to extend that interval between having your MRIs. And if that neurofilament light chain is not elevated, that'll say it's okay, probably not to have that MRI. So that's emerging as a way to use the neurofilament light chain test with MS. There's also another test that has come out called Octave, and I know some of you have asked questions about Octave before. Um, and that test is not covered by all insurances, and it's almost $500 out of pocket to the individual um, that has it done. It may not tell you whether your MS is really active, but there is the hope that within a year or two of further use of that test composite, the number of different tests being used, that it will allow us to maybe do that test once or twice a year and MRIs every 2 to 3 years, which could cut down considerably on the cost of care with your MS. The BTK inhibitors, which is another oral that's been in the pipeline now for many, many years. We thought 3 years ago we were going to see it within a matter of months approved. It is a pill that not only seems to knock down inflammation in the central nervous system, but in the animal model, it was repairing myelin. We're not seeing that in humans. One of the things that is holding this particular drug from coming to market is that all of the trials on the BTK inhibitors, and I think there have been 6 or 7 of them now that have gone into the pipeline, they're not meeting their endpoints as far as myelin repair, and they're not all meeting their endpoints as far as knocking down inflammation in the individuals taking them. But they are, in a group of people, they are causing liver injury. So it's looking like individuals who are um, regular drinkers, for example, are not going to be able to use that drug because the alcohol can inflame the liver, and that little bit of thing can tip it over the edge into liver damage. People who've had hepatitis will not be able to take that class of drugs. Um, None of the myelin repair therapies, which are looking really, really good in the animal model, are translating to humans at all. So, as I said earlier, if we can knock the inflammation in the central nervous system down with the disease modifying therapies, And also with dietary changes, taking out foods that are high in sugar or preservatives or additives or artificial ingredients, all of which can cause inflammation. If we can knock those things down, our bodies may have the ability to naturally repair damage as it happens. But again, it's all part of a big plan. It's not any one thing that does it. It's cutting down on the inflammation by using diet and lifestyle changes, by adding an effective disease modifying therapy. And so there is no one thing that does it. If you're taking a disease modifying therapy and you're eating a crappy diet, you're going to have higher inflammatory markers and you're going to have less trouble knocking down the inflammation. So I encourage all of you who are listening to this to really think twice if you're looking at a one prong approach, if you're looking at just diet and exercise, if you're looking at just a disease modifying therapy. It has to be a combination of everything. Um, Pregnancy in MS was something that a couple of individuals attended. I think I did a talk on this a couple of years ago, and we found even more information about pregnancy and medications being safe for women who are planning their families, conceiving, going through a pregnancy, breastfeeding with your medications. None of our oral medications are safe for any of that process. So if you're planning on getting pregnant, have a conversation with your prescriber about this, so that they can get you onto one of the higher efficacy B cell therapies or onto one of the older injectable medications if you do not have an active form of MS. I would say I would say if you've had a relapse within the last couple of years, you might be better served by getting onto one of the B cell therapies that's infused twice a year or on Kesimpta, which is given by injection at home once a month. Those medications have now been found to be safe during family planning, conception, pregnancy, and breastfeeding. There was a case study given on one young woman who opted, actually, before we had all of this information about the B cell therapies. She'd been on Ocrevus for a couple of years and she decided that she wanted to have a baby. So she went off of her Ocrevus. She got pregnant. She had an uneventful pregnancy, um, a normal delivery. She nursed her baby until the baby was fully weaned to table food. And then she decided, I think I'm doing so well, I'm going to go ahead and have another baby. So she conceived again, did the whole process all the way over. And when she visited her doctor again, it was 3.5 years after her last dose of Ocrevus, and she'd still had no new MS symptoms. Now, what happens with that class of drug is they actually um, suppress a certain number of B cells, which activate T cells and cause that inflammatory cytokine response in the central nervous system, which causes damage. They started looking at her B cells, and she had begun to repopulate them as normal B cells that were not activating that T cell. And so they are very cautiously using the term functional cure in situations like that. As a result, there is now a new clinical trial that has been started that has 3 arms to it. One arm has Ocrevus being given over the long haul, as many of us have done. The next one has Ocrevus being given for 1 year and then stopped, and those B cells being looked at as they're repopulating. The third one has Ocrevus being given for 2 years and then stopping and looking at the B cells over time. So if you're not currently on Ocrevus, or if you are on Ocrevus and have been on Ocrevus and want to be part of that continuing arm, um, go to clinicaltrials.gov and look at Ocrevus trials and see if there's an area recruiting in your area. Um, the let's see. I think that's it for the pregnancy portion of this. Aging and MS. We heard a lot more this year about a couple of years ago we had the DISCOMS trial that was published that came out after the conference, and they looked at a cohort of about 380 individuals that were on the older disease modifying therapies that were injectable medications, and those that were wanted to come off, that had had no disease activity or change in their MRIs in 5 years. And so one group came off their meds and the other group stayed on their meds. And statistically, there was no real difference with either group if they came off their meds after the age of 55. One group had 32% relapses and the other group had 33% relapses. The 32% was the group that stayed on their meds, and the 33% was the group that came off of their meds. But again, they were looking only at people who had been on these older injectable meds. What they're seeing now is that, particularly with fingolimod or Gilenya and natalizumab or Tysabri, people are having relapses and an increase in disease activity if they're coming off of those. So they're looking at things like extended dosing intervals when people get over the age of 60 or 65. We're not even really looking at 55 anymore because traditionally, historically, as far back as we can look, the greatest amount of progression takes place in the fifth decade of life. So we don't want to take you off your medicine in your 50s. But if you've had no disease activity by the time you hit 60, it may be safe to come off of your medication at that point. Um, Extended dosing means that if you're on Tysabri, for example, you might want to extend it to every 6 weeks instead of every 4, and then ultimately to every 8 weeks before stopping it. That may decrease the possibility that you're going to have a flare or a relapse. The same with drugs like Gilenya or Mayzent. You may be able to start taking them every other day. But again, that's a conversation you have with your doctor. Please don't do this on your own because you're over a certain age and you think you should be doing it. Um, because let's see, if you're not comfortable stopping your disease modifying therapy or going off of a disease modifying therapy at all, there are a couple of options that were brought up. One is that those of us that are over 60 seem to have very good results taking Aubagio or teriflunomide. Um, if you're taking the name brand Aubagio and Medicare is your insurer, it's going to be a hefty amount out of pocket. But Mark Cuban's Cost Plus, not Mark Cuban's, yeah, is it Cost Plus? It's not Good RX. Mark Cuban's Cost Plus does sell both the 7 and the 14 milligram doses of teriflunomide for, I think it's 21 and $34 per month, respectively. So it's reasonable for an out-of-pocket expense. They don't take insurance, so you can get that medication. The other option is to do the 2-year course of Mavenclad. Mavenclad, you take 5 pills 1 week. A month later, or five days 1 week. You may have more than 1 pill per day, depending upon your weight, because it's a weight-based dosing. You take 5 doses 1 week. A month later, you take 5 doses. A year later, you repeat that cycle. And what we're seeing now is there's evidence, there's actually very, very good data that people who have done that are now 15 years out with no new disease activity, no further disease progression. So again, that looks like it could be a functional cure. So they were things that were shared with us on aging with MS. Um, I think we've gotten to the point where we can take some of your questions. Bhavya is still online with us. And she and I were both at the meeting where all 8 of us were there sharing the information. So, Bhavya, if you could look at Facebook, Kathleen is asking, what is MOGAD? MOGAD is something that has been diagnosed as MS for many, many years. It's often seen in children. It's a myelin oligodendrocyte glycoprotein activated disease something. But anyway, it looks very similar to MS on the MRI. It generally has more spinal cord lesions than MS does. It's more of a transverse myelitis. And it is generally able to be treated and not return with a course of steroids and even a short course of Rituxan. Was there anything you wanted to add to that, Bhavia, from the one that you went to?
The one thing that I do recall them emphasizing was with MOGAD, it's like I said, it usually will cause vision loss, but it will affect both eyes, whereas with MS, you'll see it more in one eye. That was it.
Yeah, that's the same with neuromyelitis optica as well.
Mhm.
Neuromyelitis optica has been diagnosed as MS for forever. And it's really only within the last, I think, 2004, they recognized it as a completely separate entity from MS. One of the characteristics of neuromyelitis optica is that it tends to have elongated lesions in the spinal cord. It might go over 2 or 3 levels of vertebra, and that's classic for NMOSD, which you don't see in MS. MS lesions generally appear around a vessel, so there's a blood vessel in the center of MS lesions, which is not the case with neuromyelitis optica. Neuromyelitis optica also may have bilateral optic neuritis. And there's generally not the recovery with neuromyelitis optica that we see with MS, with treatment with steroids and getting onto a disease modifying therapy. There are different drugs that also treat neuromyelitis optica. Hannah says, do you have any knowledge, information, thoughts, or did you hear anything at the conference regarding the bryostatin clinical trial? Did you, Bhavya? I didn't either. I do know that they said that statins, as a rule, seem to reduce inflammation, and it was kind of a win-win situation um, with uh, with statins in general to prevent things like strokes and heart attacks and buildup of plaques in your arteries and things like that to keep cholesterol and fats down in our uh, blood. And so um, I don't see that ever as being a sole treatment for MS. But it certainly doesn't hurt to get onto a statin and knock down that inflammation. Um, Lissa, has low dose naltrexone been investigated for extreme fatigue? It has. And there have been some good results with that. People say it's placebo effect again, as what I mentioned with the fatigue medicines, but the people that seem to respond best to low dose naltrexone are those who really have slipped into a secondary progressive form of MS, and there's not a lot to really manage the symptoms of what they're experiencing right now. This seems to help with spasticity, it seems to help with fatigue. I was very briefly on it several years ago, and I found that it not only helped the fatigue, but it made me stop sleeping. And so after a very short trial, less than 2 weeks, I had to completely stop, and I was on the lowest of the two doses. It is something that has to be gotten from a compounding pharmacy, and it's about $40 or $50 a month for those of you who want to ask your doctors about it. Let's see. An anonymous attendee, how do you bring up to your doctor that you have all the issues usually seen with MS and need to be tested? Good question. What I would recommend that you do is to, and I've given this recommendation to several people just in the last 3 or 4 weeks. If you could bullet the symptoms that you're experiencing, when they started, if they come and go, um, in order to be considered an MS symptom, you need to have the symptom be present for longer than 24 hours. Uh, and it doesn't come and go in that 24 hours. And then take a half page of those bulleted symptoms to your primary care doctor. Set an appointment just to discuss those. Okay. Somebody has their hand up. Bhavya, do you want to get that one?
I'll allow them to talk. I think they're going to be asking about the neurofilament light chain.
Okay.
Jim, can you hear us?
Okay, can you hear me now?
Ken, thank you, Jim.
Okay, well, neurofilament is just because I can't read my own writing. You touched a little bit. I am very lucky that I am a patient of Doc Thrower's. I've been seeing him. I was diagnosed correctly finally in 2004 and have been seeing him since 2005. I see my PA next week and then next month for my annual MRI. Was curious, you were speaking a little bit about colorized MRIs and showing a little bit more in depth, but was there anything brought up on, I think they refer to it as smoldering MS, to where,
Yes.
um,
Yeah.
all right, because I started off, just a little background, started off on Copaxone, did that for 10 years. It got out of my system. I had 22 active lesions, and 10 years ago, Doc Thrower put me on to Sabri. And after that got into my system, and I've had the 28-day um, with that routine, and no new lesions, no active lesions on my annual MRIs. But it seems like, and I am age 6, fixing to be 61, but it seems like I am slowly having a little bit more of what may fall in the category of smoldering MS,
Yeah,
to where the
they
symptoms.
basically said we're seeing it more in older adults who've been on a lower efficacy medication or who are transitioning. They could still be getting worse slightly on an effective disease modifying therapy, and it may be a function of
Well,
age
isn't
with
Tysabri considered a efficacy
no,
DMT?
no, it's a moderate efficacy.
Moderate. All
Yeah.
right. Well then, but Ty is not a B cell, is it?
No, no, it's not a B cell therapy.
All right. Would that be something that would be potentially to coming off a tie and going on to a B cell? Because I'm happy with where I'm at. Everything, I don't really want to go making changes because if it don't stink, don't stir it. But
I would say have the conversation, but then follow it up with that phrase. Just if, I'm happy with where I am, but I just want to bounce this off of
yeah,
you.
well, that's the great thing that you mentioned. Working with Ben, we bounce stuff off of each other and keep up with stuff. So, um,
He's a good role model for other
yeah,
docs.
and he does a pretty good Jack Sparrow too.
Yeah, he does. He does.
But yeah, I'm keeping up with him and being there. And I told him he can't retire yet because I'm not cured yet.
He's way too young to retire.
Yeah, but him and his wife done
He's
bought the
younger than my
farm.
baby brother, so he's too young to
Yeah,
retire.
but him and his wife done bought the farm and they got grandkids and got more on the way. So,
I know, I know.
but yeah,
Thank you,
it
Jim.
is the stuff that you were saying though, you were hitting right in my wheelhouse, the stuff that played into what's going on with me. So I appreciate this. This has been
Thank
a
you.
good informative session. So thank you.
Thank you. Bhavya, could you let Deb speak? Deb has her hand raised.
Yes, but right before that, Deborah, we had a question from Facebook from Renee asking if you can please share your insights with Kesimpta.
Yep, Kesimpta has now had several years of use with both the clinical trial arena and also with post-approval. And it seems to be as effective as Ocrevus, Rituxan, Briumvi, Truxima. It is self-administered so that you don't have to sit in an infusion center for 1 to 5 hours to get an infusion. So it's very effective. Yes.
Thank you. Okay. Deborah,
Deborah?
go ahead. Can you hear us?
Deborah, can you unmute yourself? All right. While Deborah's trying to unmute herself, Gus asks, was there any information on the month-long Copaxone? I didn't hear anything. Did you, Bhavya?
No, not at all.
No, I haven't heard anything. Copaxone as a whole, though, is one of the least effective medications that we have in our arsenal today. So if you're stable, I would say that might be a good option for you. If you're still having disease activity or new things on your MRI, you probably need to look at something a little bit more effective. Deborah, can you unmute yourself? Okay, Ray says, would increased tone be considered as spasticity? It could be. Um, so let's see. I'm trying to juggle screens here. Uh, oh, Jim, let's see. What DMTs? Janice says, what DMTs will cause a flare in 60 years and older when stopped and for which you need extended therapy? Um, All right. As I mentioned earlier when I was talking about this, what we're seeing is actual evidence with stop in a clinical trial with stopping Gilenya or Mayzent or Tysabri, that you may have a flare coming off of those, and you may need to do some extended dosing with that to avoid that flare. Um, can heat intolerance ever get better? Karen asks. I find I'm less intolerant as I age. I'm able to tolerate a little bit more heat than I was when I was in my 40s or 50s, and and I still need my cooling vest, however. Let's see. Do we? Deborah asked to unmute.
I've been trying that.
All right. Let's see. Jennifer says, I just experienced my first crap gap with Ocrevus. What type of short-term medication would help those 4 to 5 weeks? Um, Actually, they have given permission now to dose Ocrevus 2 to 3 weeks early. So talk to your doctor and see if you can't bump up the date of your next infusion with Ocrevus. The other option, if that's not working for you, is to maybe switch to something like Rituxan, which is an almost identical medication. It's made by the same company on the same machines. It's sold by the same company. It's been around a lot longer. It just has an animal model of the monoclonal antibody instead of a humanized model, and it can be dosed more frequently. So you might want to talk about switching to a different medication altogether to deal with that if you doctor's not willing to dose it a little bit early. Um, Dinah says, prior to DMTs, a person was expected to transition from relapsing remitting to secondary progressive in 10 to 20 years. How has this transition expectation changed since the more effective DMTs have been used? We're seeing people on the more effective disease modifying therapies for 25 years or longer with no hint of transitioning to secondary progressive. For example, Rituxan was approved for other conditions other than MS about 30 years ago. And because of that, it has been used off label, and people that have been on Rituxan are not transitioning to secondary progressive. So it does make a big difference. This webinar is going to be available on our Facebook page shortly after the webinar ends via live stream. So both on the public Facebook pages, and then I usually post the link to the webinar on our private Facebook pages as well. So if you missed part or all of this, feel free to come back to this. We are right at the top of the hour. Bhavya, are you able to stay longer, or do you need to pop off?
I need to hop off, but you are more than welcome to stay. I don't see any more Facebook questions, so please feel free to stay and answer the Q&As. And I believe someone had their hand raised as well.
All right, who is it? Kelly has her hand raised. Kelly, could you unmute and ask your question?
Sure. Can you hear me?
Yeah, I can hear you. Thank you.
So I was the one who asked about the doctor. Um, I noticed that it's progressive kind of, and I've talked with people who I know in my life that have MS, and I have every single symptom down to a T from top to bottom of everything. I just lost complete control of bladder. I'm now with a Foley caffeine. I have like nowhere, no nothing.
Hey,
So,
Kelly, one
yeah,
thing you need to know is that there are more than a dozen um, mimics of MS that
yeah, I
have to be
know.
ruled out. So this is something that you need to bullet what your symptoms are, and take that to your primary care. I would set it.
I took it, and they said that they want me to schedule with an neurologist, which I already see a neurologist, but the neurologist is saying that based on my symptoms, they're like more than certain of the MS by guess as you
No,
by
no,
guess.
they can't be certain of MS because of your symptoms. They have to have, there's a whole list of things that have to be done to diagnose it and to rule out other things. So if you want to make an appointment with a neurologist to your primary care can do that, but it should be a neurologist that has more than 100 patients in their practice with MS, so they're familiar with it at least. Thank you very much. Um,
Cherie, before you continue, I just wanted to say thank you to everybody for letting me present and share my information. And thank you to everybody who attended. As Cherie said, this webinar will be available on our Facebook page, and shortly in a few weeks, it'll be available on our YouTube channel as well. Have a
Yes.
great day, and I will let you continue, Cherie. Thank you.
Okay. An anonymous attendee is asking, is it usual to be getting Rituxan every 9 months due to too low immunity, and is it still effective? Yes, it is. It's very common to do that. As I said before, Rituxan has a very flexible dosing schedule. And again, it's identical to Ocrevus in all ways except the monoclonal antibody in Rituxan is the same as that in Ocrevus, except Ocrevus is a humanized model, and the Rituxan comes from a mouse model. I am now, let's see, I am now almost 13 months out from my last dose of Rituxan, and I'm not getting infections anymore. I haven't gotten another bout of COVID. I had 3 episodes of COVID within the last 2 years. So, yes, it is perfectly safe to do that. Just click this off. Lavette said, what in your opinion is the best or more effective drug for spasticity other than baclofen? I've been on baclofen for some time and I think I need something new. Baclofen is basically the be all and end all, unless you have a baclofen pump implanted to give you a dose of it right around your spinal cord. That's much more effective than the oral baclofen is concerned, but we also see something like tizanidine or Xanaflex added to the baclofen to give it a little extra oomph. Gus asks, can you discuss the long-term effects of Mavenclad and cancer risks? You stated 15 years without needing a new DMT. The cancer risk is something that in different doses of cladribine, which is the base of Mavenclad, was high. It doesn't seem to be with actual dosing of Mavenclad. We're not seeing an increase in the cancer rates of people on Mavenclad. We are seeing an increase in cancers on those with that are on Lemtrada, for example. Mavenclad, we're not seeing that with. I think I'm going to take about 2 more of the questions that are in the queue, no more from the chat. I will go on Facebook and answer whatever questions are in the Facebook Q&A or comment section after I get off of this webinar. Shelley says, I was wondering if there was any discussion as to dry needling for spasticity. Not in the ones that we went to. No, that's not something new that would be presented there. We only bring out what's new or new information that's come to the fore that hasn't been looked at. But basically for symptom management, such as this, that's all been done. Let's see, done. And I think that that's it. So I will go ahead and answer your questions that are on Facebook. Thank you so much for joining us. Our next webinar is going to be next Monday afternoon at 4 p.m. Eastern Time, and it's Ask the MS Therapist. It's Dr. Herb Karpatkin is back with us again, so bring your questions regarding physical therapy for him. Thank you so much. If you've joined us via Zoom, please stay on the line for just a moment after we end the webinar for a brief survey so you can tell us what you want to see or hear more about in the future webinars. Thank you so much. Have a good day, everyone.